at UW-Madison. And then I went to, just a minute, I'm getting a pop-up here, there we go. Went and got my PhD in neuroscience at the University of Minnesota, and also did medical school there. And then went on and did residency in child neurology at Mayo Clinic. And now I'm doing a fellowship specifically in pediatric movement disorders at the University of Rochester in New York. So I recently moved from Rochester, Minnesota to Rochester, New York. And overall, it's been a good move. And as my husband and kids say, I am the perpetual student. I've been in school for forever, being trained for forever. But I guess one of the nice things about a career in science is you can usually get paid to be trained. So I like to tell him that I've been working all this time. I just don't make as much money as he does, but I have more fun. So, but currently as I said, I'm in fellowship, which means I'm getting clinical training specifically to treat kids who have movement disorders. And part of that involves deep brain stimulation. But then also part of it is time to work on a research project, which I'll talk very briefly about tonight.
Thank you, Angela. Chris.
Yeah, absolutely. I'm happy to be here. So my name is Chris Pulliam. Kind of like Angela, like a lot of commonalities with Angela, actually. So I'm also a biomedical engineer. So that's what I went to college to study. I eventually got my PhD in biomedical engineering. And so I work in industry. I work for companies that are developing medical devices, kind of in the neurotechnology space. I grew up far removed from Minnesota. So I grew up in Louisiana, did all of my college and graduate school and started my career. My first job was in Cleveland, Ohio. And about 5 years ago, I moved up to the Twin Cities here in Minnesota. And I'm here because I work at Medtronic, which is one of the manufacturers that creates the DBS, or the deep brain stimulation therapy that Angela just referenced. So, my career has kind of been in science and research, kind of building new technologies, and kind of look forward to sharing a little bit more with you all later tonight.
Excellent. Thank you very much. So what I'm going to do now, one more person. We do have some people coming on board who did not, I recognize them, those students, so we're good. But we actually have at this point about 6 more people than RSVP'd, so that's wonderful. I think we're going to have nearly 100% of our IC international competition students participating. So I guess if you happen to notice, go ahead and let someone in there, Angela, and if you don't, well, they'll have to wait. We'll do the best we can. I will now allow you to host so that you can share your screen. Okay. While she's getting set up there, I'll just say one more thing. I will also keep an eye on the chat okay, as much as possible. Try to hold your questions. We do want you to ask questions, verbally. But if you feel a little shy about that, we're also glad we'll try to keep an eye on the questions for in the chat. Okay.
And it looks like it does pop up, Cheryl. So I see Camilla Castilla entered the waiting room. Should I admit her?
Yes, please.
All right. Okay. So I am very open to questions as I'm presenting here. But again, it's hard to see the chat. So if you unmute yourself and ask, you can even interrupt me because I get talking and sometimes without much of a pause. So please, let's not move on if there's something I haven't explained well or something prompts a question for you, okay? And there we go. So I was given a wide open topic for tonight, and so hopefully this will work well for you guys, but I thought we'd just start with talking what is neuromodulation, And then we can talk about a specific type of neuromodulation that is what I'm most familiar with, which is called deep brain stimulation, and kind of address how can it be used to effectively treat diseases. And I'll tell you a little bit about dystonia if we have time, since that's the disease I'm most interested in. And then kind of talk about some issues that remain to be solved. But if we don't get through all of it, that's fine too. We'll kind of go wherever you guys want to go tonight. So neuromodulation, according to maybe the official society, the International Neuromodulation Society, although there are a lot of societies that deal with this. I'm a member of the International Brain Stimulation Society, but the most common definition is this one, is it is technology that acts directly upon nerves and alters it in some way, so, or modulates it. And it can do this in a lot of different ways. It can be electrical, it can be chemical. So I put up some examples here. So we'll start with the one on the far right. Can you guys see my cursor? Oh, Cheryl, you're muted, so I don't know if you're trying to tell me.
I cannot see your cursor.
All right. Okay. Well, then I'll just explain. So the image on the far right is for treating spasticity, and it delivers a drug called baclofen. So you can see there are leads or cannulas going directly into the spinal cord, and then there's a port or extension that goes from that to the container that actually dispenses and holds the medication. And this helps us kind of deliver the drug a little bit more effectively to specific nerve areas rather than a medication that you swallow and goes throughout the body. So sometimes that can help us avert some side effects. And then moving clockwise or to the left of that, oh, actually, I mixed those up. So that's actually the baclofen pump, which looks very similar to spinal cord stimulation, which uses electrical leads instead of a cannula to deliver electricity to specific areas of the spinal cord. And that's similar to deep brain stimulation, other than just using a different area of the nervous system. And so therefore a little bit different equipment. And then moving to the picture of the guy in the purple shirt is what we call transmagnetic stimulation. And so this big machine uses magnetic fields to induce currents, so small electrical currents in specific areas of the brain. And so that's somewhat similar to brains. Well, it is a type of brain stimulation, but you don't actually have to have any surgery to deliver it. But some of the drawbacks is that you can't reach deep areas of the brain, and it's not quite as precise with its localization. And then on the left is something that's a little less well-known, but one of my favorite projects because it was being developed at UW-Madison while I was an engineering student there. And that's using stimulation on the tongue. So you see the guy on the cover of Life magazine, and he has some kind of, it looks like a tube going up into his mouth, but it's actually an array of electrical wires. And that is delivering kind of like little prickly electrical sensations to his tongue. And why I thought this was cool is they weren't trying to do anything specifically for the tongue. It's actually being used to treat people who have balance disorders and provide a different kind of sensory feedback. So some people might not think of this as neuromodulation in the strictest definition or traditionally, but I think it's a cool example of maybe some things we're going to be able to do in the future where we can do less invasive type of stimulation and have it affect other areas of the brain because of this idea that lots of different areas are interconnected. And we'll talk a little bit more about that later too. Any questions before we go on? All right, I won't always ask that. So again, just interrupt me if you do have questions.
I have one.
Yeah.
So is acupuncture, acupressure in some way related at all?
So yeah, so I'm not an expert on acupuncture, but certainly there is a thought that you are either changing sensation or possibly changing the way nerve endings are being affected. Yeah, I mean, I think we'd have to do a little bit more careful analysis of what are you affecting when you do acupuncture, because you'd have to be affecting the nerves, but we have lots of sensory nerves, and it's believed that it affects pain perception. So in that way, it's affecting it somehow. And possibly changing some of the chemical messengers around the nerve endings. But again, I'm not much of an expert in acupuncture.
Yeah, Angela, I can maybe add a comment there.
Yeah.
It's actually a really great question, Cheryl. There is, I can actually think of one neuromodulation therapy that traces directly back to acupuncture. So there's for overactive bladder, there's actually a nerve in our leg that had I think traditional Chinese medicine was like a target of acupuncture. And now people are looking at that as one of these ways, like Angela has some of the nice diagrams here that show like electrical stimulators that you can implant. That's become a target, an anatomical target for places that will deliver electrical therapy to treat overactive bladder. And then it traces back to that history in acupuncture. So that's a really good question. And there are some examples where that's becoming, real life. People are actually building medical devices out of that.
Well, that's very cool. Thanks for adding that.
I had a quick question too. I don't think you said, and maybe I'll get into this later, Angela, but where you showed the pictures of the pump, the medication pump and the electrical stimulation, what kinds of conditions might those be used to treat?
Yeah, so, the spinal cord stimulation is being used mostly to treat pain. And again, Christopher might be able to add more to this from his experience at Medtronic, but it's being used a lot to treat pain. In research, it's being used to try and help people with spinal cord injuries actually gain more use or function of usually the legs to help them walk again. But that's not a common indication yet. And then the medication pumps with the baclofen. So I'm glad you called me out on this because spasticity is not a term, something I use every day, but most people aren't familiar with that. So we use it a lot in kids who had brain injuries at birth. A lot of times it's a diagnosis of cerebral palsy, but it can be other neurological conditions can cause kind of increased muscle tone or tightness. And baclofen is a medication that can help with that. And sometimes we just want it to go to a very specific area like the lower legs, because if you take the oral medication, it can affect the trunk and muscles that we use for sitting upright and keeping our heads up. So sometimes these therapies can be really helpful for making it more targeted.
Okay, so but the medication in particular would be similar to like a spinal anesthetic where you can target precisely what part of the body you want to treat.
Yeah, and as a child neurologist, like I said, I'm most familiar with baclofen, but a lot of different medications, like you said, anesthetic medications for pain can be delivered this way too.
What are the risk factors of sending electrical signals into the nerves like a spinal cord?
Yeah, so spinal cord, well, let me start with the brain. So going into the cortex, the part of your brain that's inside your skull, especially on the surface. So there's something called cortical stimulation, which is on the surface of the brain, rather than deep brain stimulation, which is the deeper structures of the brain. You're at risk for seizures. And then because you're adding electricity to the brain. With deep brain stimulation, since it's the deeper structures rather than the surface is much more prone to generating seizures. There's less of a risk for seizures, but anytime the electrical currents go to outside the area that you want to stimulate, you're going to get side effects. So if you stimulate an area of the brain that does sensation, then you're going to get abnormal sensations. So commonly seen is people say their arm is tingling, that feeling you get when you have your legs crossed for too long or your arm falls asleep. That can be a common sensory side effect, or just numbness. If you stimulate a motor area, you can get activation of muscles. So sometimes we see facial pulling. It can affect some of the tongue muscles for speech. You can actually get tightening or pulling in the hands or the foot or the leg. And then we see a lot of mood changes too. And or I shouldn't say a lot, but that is a definite side effect and something that I think we don't know as much about because it's much harder. I mean, if I'm working with a patient, I can see their face twitching or a muscle pulling, and they can usually describe abnormal sensation pretty well, but it's much more difficult for them to explain or describe like a change in their mood. Does that make sense? And then in the spinal cord, it's going to be the same thing, but I guess the pathways, because they usually don't go as directly into the neural structures themselves. Again, I have less experience with that, but I think the side effects are less than compared with the brain.
Yeah, that's definitely true, Angela. I think for spinal cord side effects, you typically, so we're activating those sensory fibers there. So patients will report like maybe tingling, just like you do in the brain. But I think probably the main thing you may hear is the intensity of the sensation can vary because like in the spinal cord, we've got this like big metal lead and it's kind of sitting next to the nerve and it can actually move around. So if I bend over, it may get a little bit closer. And then when it gets closer, I feel it a lot more intensely. So patients will report like feeling a jolt or a shock. If there are certain things or certain movements that they make where the lead and the spinal cord get closer together or farther apart. So that's a common side effect, I guess I would say, in the spinal cord is just the fluctuation or variability of the sensation, and sometimes it gets uncomfortable.
Any other questions?
I think Lauren had her hand up earlier.
All right, Lauren, do you have a question?
Oh, Lauren said her mic is broken.
Oh,
Okay, that's too bad, Lauren. Maybe if you have a question, you can put it in the chat.
all right. So moving on to deep brain stimulation. So I've listed just some of the disorders that it's used for. So some of you may be familiar with Parkinson's disease or may not. But this is a condition where individuals have depletion of a substance called dopamine, which is a chemical transmitter in the brain. And this leads to slower movements, rigidity, problems with walking, and often a tremor. Different tremor conditions, particularly something called essential tremor, where people often get shaking of their hands, but it can be other parts of the body as well, respond really well to deep brain stimulation. It's being used more frequently to treat epilepsy or seizure disorders. And then dystonia, which we may get to tonight, is what I'm personally studying, and that's where individuals have abnormal, sustained kind of postures or contractures of the muscles in different areas of their body because those muscles are getting activated inappropriately. And then it can be used for psychiatric disease. It's becoming more common and getting better benefit in individuals with obsessive compulsive disorder. And they're looking at trying to use it for other types of mood disorders. Well, not that OCD is a mood disorder, but more common mood disorders like anxiety or depression. And then another movement psychiatric disorder is Tourette's syndrome. And then, as I mentioned, there's lots of areas of research trying to figure out, are there other conditions where it'd be useful for? But we just wanted you to understand that traditionally we think of it with movement problems, but it's kind of moving past that realm and being used in a lot of other areas too.
I have a quick question here, and maybe I don't want to take too much of the kids' time. I have another question that came up, so we'll make sure we get to that, Michelle. But I'm very familiar with Tourette's syndrome. My brother had that. I'm just wondering how long you've been doing something with that. He's been gone since 2013. So this is maybe new. This would have been wonderful for him. And then I heard your brief description of dystonia. What's the difference between dystonia and Tourette's syndrome?
Yeah, okay. So I will, if we get to it, I'll give a little bit more information about dystonia and actually show a video, which I think will be more helpful. But dystonia is this abnormal activation of muscles, usually due to damage somewhere in the motor control network. And so if you think about it, when you move, when you're going to like flex your arm, the muscles for extension have to relax while the muscles for flexion contract and pull. And in dystonia, that's not working correctly for individuals. So they kind of get what looks like cramping postures, but sometimes it can manifest as a tremor too. For Tourette's syndrome, we think of that as patients have what we call tics, is kind of one of the primary manifestations. So these are sort of quick, well, often quick movements. Sometimes they can be a little bit more complex, and they can be vocalizations as well. So common tics are things like throat clearing. A lot of times we see kind of head or neck movements and different gestures. But Tourette's is a complicated, it's called a neuropsychiatric disease because it has the motor part of it with the movements, but it also had people with Tourette's syndrome are much more likely to have anxiety, OCD, attention deficit problems. And so that's why it's thought of as a syndrome.
Yes, okay, so it's a lot of things. So I'm just going to quickly here, Michelle, basically her comment was she really appreciated that you called out the similarities with the pacemakers and ICDs, that this is what she's finding in her research. So I think this is really going to help students as they've read this to hear this now and really be able to apply this. Lauren says she also has familiarity with Tourette's, and she says, does the DBS help with the tics in a form of barks? Now, another form that might be related to that is verbal. That verbal piece you
Mhm.
mentioned, swearing. Fortunately, my brother did not have that one. He was the full body jerks and the clearing the throat and that. But the barks, so Lauren's question is the barks, I'm going to kind of add to that the other verbal things.
Yeah. So using DBS for Tourette syndrome is kind of a huge debate in the field right now, and what I'm very interested in. So it's by definition has to start in childhood before the age of 18 years. And it usually starts much younger. Like most kids we see are early elementary school when they're first getting diagnosed. And then symptoms tend to get worse between ages 9 to 11, and then get better with puberty. But I should clarify that tends to be the motor and vocal symptoms. And a lot of times, if individuals do have the psychiatric symptoms that are also very common, then those tend to get worse as they get older. So some people have argued that even if the motor tics and vocalizations are really severe, we shouldn't treat kids because they'll likely get better just without any intervention as they get older. And other people argue, boy, if you have really severe tics, this really impacts your development and what you can participate in, how you see yourself. And so we shouldn't be waiting to treat people. So currently, you have to go before an ethics board if you're going to get treated with DBS. Well, maybe not at all institutions, but most universities who are doing this, you have to get approval by the ethics committee if you're under 18 and going to be treated with the DBS for Tourette syndrome. And then the outcomes have really varied. So because of that, most of the studies have been done in adults. And I've personally seen some college age kids with very dramatic reduction in their tics. But a lot of case reports have found that the symptoms of Tourette syndrome, they tend to wax and wane on their own. So by wax and wane, I mean, they'll be really bad for a couple months, and then whether we give medication or do anything about it, they'll get better for a few months. And so the same thing can happen with deep brain stimulation. And you can have what's called a placebo effect, that just by doing some kind of intervention, it affects the brain in ways we don't totally understand. But we know that just the thought of doing some type of intervention often makes people have a good response in medicine. And it's very, very hard when you're doing studies of deep brain stimulation to come up with a sham surgery or a way of having a control group of people who don't get the intervention and people who do get the intervention, but they don't know that. So some people have argued that perhaps a lot of the success we've seen is because of that placebo effect. So I think it's just really not known how well it works. As a clinician, we kind of save DBS, and I see a lot of Tourette's patients actually, but we save DBS for severe cases that have kind of failed all medication. The tics are really getting in the way of activities of daily life. And then, typically wanting to wait until they're adults, but not always. And that's kind of one thing I was hoping to get into too, is for a lot of these disorders, we have targets within the brain that we try to place the leads into. So if you kind of see on the diagram there, you have the stimulator, and it sounds like many of you are familiar with this, and that's usually placed somewhere in the chest. Sometimes it can be in the abdomen or stomach area too. And then you have this extension wire that runs from the stimulator up the neck into the brain. And then it's where the tips of the electrodes or leads are that actually delivers the stimulation. And so for all of these different conditions I've listed here and the other ones being studied, we have different targets in the brain of where we want that electrode tip to be. And we think that is very effective. But it's expensive to do research on it. And a lot of these conditions, we don't truly understand where is the tremor generator in the brain or what part of the brain is responsible for dystonia. And so and same with Tourette syndrome, it's a very complicated disease with a lot of different symptoms involved. And so, one question you can ask is, are we stimulating the right area? Can we say, is it effective or is it not effective? Or do we just not have it perfected yet?
So I was just going to add, my brother was born in 1951. And one advantage, all of our students here, and of course adults will already understand, is that he was not diagnosed until he was 17. These kinds of things are diagnosed much sooner. So what happened to my brother was these large body jerks, and he was a big guy. I mean, I remember myself, his elbow hitting me and literally throwing me across the room. Well, what happened was very counterproductive. Everything that happened that he had no control over was treated as discipline, which only made his condition worse. Nowadays, these things are diagnosed much earlier. And look at all of the things that Angela has shared here that are possibilities as we learn more and help these people. So with that, I want to take it to Camilla, who says, is DBS part of neuromodulation? Also, are some symptoms, mood swings, and twitches for both, or just neuromodulation?
Yes, so deep brain stimulation is a type of neuromodulation. So again, the definition of neuromodulation is going to be any sort of, can be device or chemical stimulation that is going to alter the activity of the neurons. So that's kind of a big category. And within that, we have things like the transmagnetic stimulation, the drug delivery pumps, spinal cord stimulation, deep brain stimulation. So these are all specific types of neuromodulation.
I have to say, I'm really proud of you students. You can tell they've been working on their research. They're coming with great questions. Okay, I think maybe we move on a little bit more here, and we'll have to watch our time to make sure that we get Chris time also.
Yes, I definitely want to do that. I think this is probably the best slide I have because I have a video showing dystonia before and after deep brain stimulation. So if you look here, this is a boy, this is with dystonia. And so you can see he's having trouble sitting upright. And he's having a lot of pulling at his shoulders, which is what is making his arms kind of jerk around. You see, when he lets his shoulders just go where they want to go, then he can move his arms much more, I guess, regularly. We'll just skip ahead a little bit here because you get the idea, but I want you to see him walk. And again, this is a very, very severe case of dystonia. Much more severe than I usually see. So we do use DBS for less severe cases than this.
That's brilliant. And come back this way again.
So again, you can see these abnormal postures that he has because his brain is activating his muscles in an inappropriate pattern. So then he gets DBS. This is 6 weeks later. And you can see his symptoms are much improved. He's sitting up a little bit better. He's not having that shoulder pulling. He's moving more easily, but he still has symptoms of dystonia.
Okay. That's it. Okay, and to the left again.
And I'm just going to jump a little bit ahead of here. And now 6 months,
Just put your
you'll
arms
see
up
symptoms
as
are
much as
even much
possible.
more
That's it,
improved.
back on. Just hold them there for a second. That's fantastic. One of those, yeah. Okay, and go from one to the other as fast as you can. Okay, and the other hand. Let's get up now. That's it.
So watch his feet and you'll see just a little bit of the dystonia still present.
Okay.
But probably most of you wouldn't even look twice if you saw
Okay, that's
him
fine.
walking down the sidewalk.
Sorry about this.
But that right foot does
Almost
turn in
good.
a little bit.
This young man really needs to be commended for allowing his video to be shared to tell his story. This is
Yeah,
this
was
wonderful.
published in one of the neurology journals. But yeah, I think I guess I don't have the date on there, but I think he was one of the early cases. So, so I think that gave you a good idea of what dystonia is. And we talked a little bit about this, but then I just want to quickly mention it again, and then we'll let Chris go on to his talk. But
One quick question before you move on, because
Mhm.
this question is relevant just before you go into this. Out of curiosity, does dystonia change over time like Tourette's? On its own, I think is the question, right? Laura?
yeah, so I think it depends on what is the underlying cause for dystonia. So a lot of types of dystonia are caused by changes in the gene, and so, or the DNA. And so those start in childhood. And sometimes they get really bad and then symptoms kind of plateau and are stable. A lot of times they're what we call neurodegenerative, which means they keep worsening. Occasionally symptoms get better, but that's much, much more unlikely, unfortunately, for dystonia patients. And then if the dystonia is due to an injury, so a lot of times we see dystonia symptoms in kids with cerebral palsy, and that's much more likely to just kind of stay the same and not change as much too. One thing about the dystonia that's really interesting is the symptoms can really get worse with any type of stress. So it can be things that you might expect it to get worse with, like an illness, but even just anxiety, having to perform, have a test, can often make dystonia symptoms worse too.
And that's with Tourette also. I saw it with my brother.
Mhm.
Stressful situations, a tool he had to learn. And he was quite well into adulthood, was separate himself from the situation.
Yeah.
Okay, Lee says, I used to handle commitment cases for a local county. Lee here is speaking as an attorney and
Mhm.
learned that certain psychiatric medications can cause tardive dyskinesia. I'm not saying it right. I think that's the spelling, and that related to dystonia. Could DBS be used to treat that?
That's a question that's been thrown around. So yes, there are medications that have this effect. And so it can look like dystonia. It can look like something we call chorea, which is extra movements. And the term is tardive dyskinesias. And so usually, ideally, we catch those symptoms before the person has been on the medication for too long, and we stop the medication and it doesn't get so severe. As far as using DBS for it, believe I've seen a few case reports. And so I think it's something people are thinking about, but it's not something that's commonly done. And I wouldn't be able to say this is the site that you would try. I think it would depend on whether it was more dystonia versus chorea or just what the symptoms were.
So Lauren says, since this is FPS, future problem solving, okay, Their future scene that they're going to look at is going to be at least 20 years into the future. Do you think that DBS could be used for minor difficulties in the future?
I think those of us who really believe in this therapy hope that would be the case. I think neurosurgery has come a long ways, but this is still a major brain surgery. So in order to get those leads into the brain, you have to actually drill a hole through the bone, the skull, and then you're at risk. There's a lot of blood vessels that traverse the brain. And so one of the risks of surgeries is that you could have a brain bleed if one of those blood vessels were to be hit. We do a lot of imaging, and the neurosurgeons are very good at it. So I think the risk is relatively low considering what we're doing, but that's a risk. And then there's the risk for infection too. And so that's kind of what's keeping traditional deep brain stimulation like this from being used for minor procedures, because the risk kind of outweighs the potential benefit. But I think what we're going to see in the future is the concept of using stimulation, but can we do it non-invasively? Can we do things like make a network of magnets so that we can induce electrical currents? Currently, it's very hard to target these deep structures, but if our engineering gets better, can we do it non-invasively? And also with the magnets, it doesn't seem to last, but can we somehow get our engineering good enough that we don't need a whole big machine, and we could just do it with some kind of device that you can wear in a baseball cap? So I think that's maybe where it's going to go. I'm sure Christopher has some things to add to that too.
So Camilla, I think she might have just answered your question. She said, are these neuromodulation treatments mostly electronic stimulations, or are there also some implants? So a combination. It could be worn in a baseball cap maybe in the future.
Yeah, and you also have to think about chemical too. So don't forget about not just electrical stimulation, but being able to deliver, different neurotransmitters. Like maybe someday it won't just be stimulation to treat Parkinson's disease, but we'll actually be able to deliver levodopa, which is one of the neurotransmitters that is not produced very well in Parkinson's disease. Maybe we'll be able to deliver it directly to different areas of the brain.
So in relation to that, Michelle says, with electric pulses, spinal pumps, and magnetic stimulation, how much fine control is there? And is limitation in treatment more because of lack of understanding of different conditions, or is the technology mechanically limiting treatment?
All of the above. All of the above. Yeah, and fine control. Boy, I have some slides, but I don't want to take away from Christopher's time. But yeah, you can't deliver stimulation to individual neurons, nor would we know which neurons to target. So you're looking at structures. And then, as I mentioned, your electrical current, they've developed some technologies to try. Well, let me just quickly go to it because it helps. So mostly when we do current, we're basically creating little bubbles or spheres of stimulation. And you can activate different nodes kind of in that hourglass figure that's up at the top to get different shapes to the current or stimulation. And you can change what's called the anode and cathode, or the positive and negative currents, to try and kind of rein that in and keep the stimulation from spreading as much. But you're still kind of limited to, you're going to activate a certain area of tissue and it's going to spread. And so if the electrode isn't placed just right in the brain, you're going to get side effects. Now, the picture on the bottom is what one company has come up with, and I think actually a couple of companies are using it now, and it's going to become standard very soon, is you can see rather than just having a solid ring, so these electrodes, they're 3-dimensional and round. And rather than just having a solid ring that you would get a sphere or a circle of stimulation, they've divided that ring into 3 separate contacts. And so it doesn't just shoot the stimulation out in one direction like we'd like it to be, but it at least changes that sphere. And the picture on the bottom right, that green blob, I don't think it works quite as well as they like to depict with it only staying to one side of the electrode, but at least shifts it so that, you know, the stimulation is directed more in one direction. And so it's kind of getting better at helping us target smaller, more discrete areas of the brain, but we still have a ways to go yet.
I think we've heard some answer to this, but let's just get a little clarification. So I'm going to read Camilla's question, and then we'll turn it over to Chris, okay? So
Okay.
Camilla says, what makes neurological treatments and surgeries better or more different from regular surgeries to the central nervous system?
I might need you to rephrase that question a little bit, just because any surgery to the central nervous system is going to be a neurologic surgery. So maybe you can just help me out a little bit. Anybody, what exactly you were trying to compare there?
Angela, maybe if you could comment on kind of like a technology-based intervention versus like a surgical approach.
Perfect. That's I understand the question now. Thank you. Yeah, so traditionally, the way we figured out that deep brain stimulation might be useful is they used to actually do lesions that were called pallidotomies, where they'd actually use electrical current to kind of burn holes in that area of the brain. And they found that the lesions would often help with the symptoms, but the problem is then twofold. One, you've got a lesion in your brain and you can't go back and undo that. And then with a lot of these conditions, we find that patients do better. It's not like they come and we program their stimulation and then they're just good for the rest of their life. They have to keep coming back to clinic and we have to keep tweaking the stimulation settings, more so for some conditions than others. But it just seems like the brain wants to revert to kind of bad programs or bad habits. And so that's what they've seen with the lesions, not always, but a lot of times, is that it works really well initially, but then over time, the effect kind of wanes. And at least with the stimulation, you can keep kind of tweaking it and optimizing it.
Okay, thank you so much, Angela. At some point here, I know you're going to hang on a little bit longer, but Angela is an hour ahead of us and she's got children to get to bed. So if everyone would go down to their reactions and give her a round of applause. And if your camera's on, thank you, thank you, thank you.
Yeah, my pleasure.
Did you hand it over to me or did you give it to the hosting to Chris?
I have not found my tab yet to
go to participants.
Okay.
And then that should come up on the right side.
Yeah.
And I think you can hand it over to Chris. We're learning, folks. This is the first time we've tried it. If not, just hand it to me and then I'll hand it to Chris.
Yeah, I am not seeing the tab to.
Okay, so go on Chris's name.
Okay.
And then under the video, just put your cursor on that or click on it. And it'll give you some options.
All right, got it now.
And I think I have it. Thanks.
All right, yay, we learned something else new today. Much simpler than neurotechnology, but wow, thank you.
Okay, so I'm gonna see if I can actually share my screen.
While he's working on that, I'm really so proud of you guys for the great questions. It's I'm hoping that by the end of this evening, you are even more inspired to ask more questions. And if you can't find something in your research, I'll just bet if you had your coaches email those questions to me and I sent them out to Chris and Angela, I bet they would help us out.
You got it.
Definitely.
Thank you.
Okay, so yeah, Angela, thanks for that, because there's a lot that, like, I work in the space. Angela actually practices medicine, so I'm always in awe of doctors, and I kind of work on the kind of device side of building the devices. But I'm going to talk to you guys about something completely different. So I won't talk to you about DBS at all. I'm actually going to talk to you a little bit about brain-computer interfaces. This is like a different element of neurotechnology. So I was going to actually start off with a question. You can put it in the chat, or if you want to unmute, but anyone brave enough maybe to share what you think of brain-computer interfaces if you've come across that in your research already?
Go ahead and make a comment. Even if you say you haven't heard of it yet, let us know.
Yeah, any feedback?
I'm typing a paragraph. It's pointless.
Michelle, go ahead, talk.
Oh, is it when you sort of manage to connect another sense to the brain, like existing brain, because
You're exactly right, Michelle. So I have a couple pictures. This works. So we talked a little bit about deep brain stimulation. So there's that. Can you guys see the red pointer on the
Yes.
screen? Okay. So Angela had some nice, and Lee, I see your question about related to. You're exactly right. That's like a great potential application of brain-computer interfaces.
Okay, artificial limbs, yes, and another
Yes.
one's cochlear implants.
Yeah, and that's another really good one. So that's a you can think about that as cochlear implants, or I would say they're pushing information into the nervous system to help people with hearing impairments hear. Brain-computer interfaces are typically, they're trying to pull information out of the brain so that we can try to do something with it. So in this kind of cartoon, what it's drawing is you've got some technology that you can interface with the brain. There's non-invasive ones, so you can put little stickers on your scalp and you can measure brain waves, or there's invasive methods like the deep brain stimulation electrode that Angela shared with us. So whatever technology you have, you can interface with the brain and you kind of pull these signals out. You can do some processing with them. And then a lot of the time in these brain-computer interface applications, you're trying to like do something in the outside world. So an example might be if you had someone, let's say that was paralyzed. So Angela referenced spinal cord injury. So that's something where you have an injury to your spinal cord, and in some cases you're paralyzed or you can't move below the level of that injury. So there's actually some researchers that they've built out some technology. So here's an example of the technology. So this kind of grid gets put into the brain. You use that to measure the brain's activity. And then when a person who can't actually say the words, let's say they can't communicate, when they think about it, you can kind of build these these software applications that take the information from the brain, they process it, and then they're able to maybe tell what the person was trying to do. Let me pause. So Sam, I see your question about EEG being non-invasive. That's exactly right. So I was referencing, and again, you guys have done great research. I was referencing like the little stickers that you can put on your scalp. So that's what EEG is. So that would be, I could, I'm sure Angela could take me into a lab and, probably shave my head and adhere a bunch of little electrodes to my scalp. And then you can measure brain activity that way. With EEG, it's non-invasive, but it's not terribly specific. So as you get to, places like this, you can measure down to like individual neurons and how they're firing versus like big gross measurements with EEG.
And what does EEG stand for?
Good question. Thanks, Cheryl. It's electroencephalogram.
Okay.
I think I pronounced that correctly. Let's see. Lauren, you have your hand up. Did you want to come off mute and ask a question?
Yeah, can you hear me now?
Yeah.
Okay, I had the wrong microphone clicked on. But my question was, so we saw a story in our research about a guy who I couldn't see colors or couldn't hear, I can't remember which one. So he attached an antenna and then put like a little microchip or something in his brain, and then it helped him process the colors or heard better. Would that be considered a brain-computer interface?
I think that's a really great application of like a neurotechnology. So you think like, I think there was a comment about prosthesis or like a prosthetic application. So like a cochlear prosthesis, this could have been, like a visual prosthesis where, there's different things that can go wrong with some of the nerves that and kind of how our eyes take in light. So you can actually develop prostheses where you can stimulate something here in the eye. There are actually prostheses where people stimulate in the back of the brain to restore kind of different elements of visions. Those are other really good applications of neurotechnology. Connor, I see your question or your comment about, is the person thinking hello world? Yeah, that's in this kind of cartoon, that's exactly right. So they're kind of just trying to, in a kind of cartoon or schematic, just show this linkage where the person isn't actually writing hello world. They're thinking about something or they're imagining doing something. And then the brain computer interface is able to kind of decode that information to tell what they're trying to write. So that's a great question. Other comments or questions?
Oh yeah. Okay, so Stephen Hawking has ALS. So does that have to do with this?
That's a great question. So I'm going to go, actually, maybe I'll just stay here. So ALS is another neurological disorder that can result in patients being paralyzed and not being able to communicate. So that's actually, it's a disease that's a very, I wouldn't say common's probably not the right word, but it's a very impactful opportunity for brain-computer interfaces because, in ALS, as it's, as it gets pretty advanced, like cognitively, a person with ALS is still intact, but they can't move, they can't speak. And just imagine like what that's like on a day-to-day basis where you can't communicate with the outside world, but you're still in there, right? You're still there and you're thinking, you're feeling, and you have observations. So BCIs are a common kind of thing that people work on, and communication is one of those challenges given how big the impact is on patients with ALS.
Camilla says, could this help communicate both ways from the brain to the computer or
Yes.
from the computer to the brain?
You all are great. These are really, really good questions. And short answer is yes. So there are some researchers who are not only pulling information out of the brain, but then they're putting information back into the brain, maybe in some other ways. So maybe for a person with spinal cord injury, where they would like to move their arm, but the information, when they try to move their arm, that information doesn't get down to their arm because there's kind of an injury here that doesn't allow that information to get down. You could imagine kind of maybe taking that information out, you could do something with it, and maybe you could put information back in so that they feel their arm move when it moves. So yeah, there's really cool applications where you could think about taking information out and putting information in. This application, or this example, I guess I'd say, is just focused on taking information out. It's a really great question, Camille. So I want to be sensitive to time. The drawing, the person hooked up by wires. Yes, yeah, that's another good one. I'm going to try to show you a couple of videos actually, because I think these are cool.
So in case anybody hasn't seen the question while he's getting there, in this drawing that was there before is the person hooked up by wires. Do you think that this tech could be used in everyday life while not connected to a computer?
Mm-hmm.
So here's
so I don't know. So short answer is yes. I'm going to try to show you a video here. We'll see if it works. So I'm going to maybe pause there and make a couple comments. So it's a small company. It's based, I think it started out of actually a research lab in Australia, and now they're kind of turned it into a company. And they're building this new technology to pull information out of the brain and kind of really make a brain-computer interface that allows those that have the implant to kind of text, email, shop, and bank. So not quite as bulky, you're not tethered to a computer all the time. Like, how can we make this easy? let's see.
The inside highway into what we're doing
We go back
is for
up.
people who have lost their.
So you're going to see a little animation of a brain. And what's really cool about this particular technology is, you know, Angela shared like the video, like the images that have the deep brain stimulation electrode, and she spoke to how invasive it is and how that kind of puts up barriers to making the therapy, or at least maybe getting the therapy to more patients. This technology takes a different approach. It takes what they describe as a minimally invasive approach, which is rather than drilling a hole in the skull, they use the fact that we have blood vessels all throughout our body, including in our brain, and they actually, you know, go through the blood vessels to place an electrode there. So you'll see kind of a little bit of an image of that.
Physical independence. What we're doing differently is using the blood vessels as the natural highway into the brain and lacing the inside of the blood vessels with electrodes or sensors that can record activity from the brain.
So if you've done any of your research where, like, you know what a stent is, so a stent is a device you can put it inside of an artery. So if like an artery is blocked, you can place a stent inside of an artery and it kind of helps open it up. So like my dad had a stent placed. What they did was they kind of looked at that and they said, that's kind of interesting. It's non-invasive. There's ways that we can get stents to different places, different arteries in the body. Can we get one all the way to the brain? And then can we put electrodes on it so we can measure brain activity? And they've been pretty successful doing that. Sorry. There we go. This is what I wanted to show you.
That platform then is like a Bluetooth out of your brain to control a computer or a device where there is no need for a keyboard or a mouse. This is a truly hands-free, brain-controlled platform.
So, Lauren, I think you asked the question about being tethered. So in this version, so this is all kind of investigational, they're doing research with it. In this version, he is still tethered. So if you can kind of spot this box that's on the table next to the computer monitor, that's, you know, that's his tether. But what they're working on next will be something he can just wear in his chest, and then it'll pair with his phone, and there's no need for anything in the middle. So the technology is advancing to a place where it becomes a little bit more wireless, a little bit less burden on the patient. So yeah, that was a really, really good question that you asked. And there are groups that are working on that all kind of all over the world. The other thing I may show you is, if we have time, I'll show you this other video. So this is a different approach. So this is a monkey. This monkey has an implant in his brain. I don't know if you can quite make it out. There's a little ball patch on top of his head there. So that's where he had the open surgery, and there were some wires that were implanted into his brain. And this is a company. So I don't know if anyone knows anyone that drives like a Tesla, the electric car. So Elon Musk he's an inventor, and I think he founded Tesla. He's also got this other company that's working on brain-computer interface technology. So they have some things that they're working on. This plot that you see here is kind of a way of visualizing the brain data that they're able to measure when the monkey's doing this task. And what they're doing is they're taking that brain data and they've mapped it to the monkey's playing Pong. So I don't know, maybe some people don't know what that game is anymore, but you'll see this white bar go up and down, and the objective of the game is to basically bounce the ball off of your wall here and to bounce it into an open space of your opponent. So the monkey's playing Pong, but it's all based on the brain data that they're recording. So they're recording the brain data. They're, basically they identify patterns, and the monkey has learned how to change the brain data to play Pong. So we'll play a little bit of this as well. So what you're seeing here in the bottom left is, time's going by, they're measuring brain activity, and then, it's changing. You can see, like, just when you look at it, you can tell it's not static, it's variable. And that's reflective of the monkey, modulating brain activity. And then they've got a computer program that they wrote that allows the monkey to control the position of his wall in the Pong game. So this is another example, it's kind of, it's a monkey, so it's a little bit different than like a human application. Great question, Connor. He's only playing one side, I think, in this video. I think it's just one side. That's a good question. Camilla, I see you have your hand raised. Did you want to come off mute and ask?
Yeah. So is that monkey like doing it just with his brain, or does he have like a remote?
Yeah, great question. So the remote is used when the monkey's learning to play the game. So researchers that do kind of work with non-human primates or monkeys, they'll often they have to teach the monkey to do something. So you see them kind of holding on to this little like metal spigot there. Like they actually get like little juice rewards. And then they often start with a controller or a joystick, and they kind of learn to play the game that way. And eventually you take the joystick away and it's all based on brain activity. So right now it's just the brain signals that are controlling, that he's using to play the game, but they use the joystick to teach it.
Also, so like because of that bald spot, the monkey had like, he got the implant like through surgery. Are there other ways? Because earlier there was like a video about how messages go through like the veins in the bloodstreams. So could it send like an electrical signal, or is it just through surgery?
Oh yeah, good question. I'm gonna try to go back a slide. See if this works. Yeah. So if I'm understanding your question correctly, and you can kind of ask it again if I'm missing it. Our brains, like the way like all the axons and the neurons in our brain communicate, it's all electrical. I guess it's ions ultimately. So if you think about chemistry, you have sodium and potassium, and they're charged and they move in the brain. But as those things happen, we can actually measure that. So we measure this electrical activity. Now, your question about the kind of the vascular supply, there are different ways of getting electrodes in the right place to measure that activity. And some of them might require, opening up a hole in the skull like you do during DBS surgery and putting an electrode in that way. But other researchers, I guess, are looking at other ways that you can kind of do the same thing. So you kind of have to have, at least for some of these like really specific recordings, there has to be some way of getting like a wire close to the part of the brain that you're interested in listening to. So you can kind of come from the outside in, or that other approach, it was kind of coming from the inside up to the brain and through the blood vessels. So there's different ways you can look at kind of approaching it, but to get specific recordings, today's technology, at least, you kind of have to get a wire close. In the future, who knows? There may be other really sophisticated things we come up with that, you talk about, Angela talked about the hat and the kind of magnetic stimulation, but you could envision similar technology advancing to the point where you can actually measure activity of the brain that way as well. So that's definitely kind of a future opportunity. Good question. So I don't have a lot more content. So I think, just in terms of presentation, I think these are really great questions. And Cheryl, I'll let you kind of keep us honest on time.
Well, what I will say is we really want to respect your needs. And students, if you feel like you need to go for whatever reason, please go ahead and log out. But as long as Chris has time.
Yeah, I'd be happy to hang out for another, I'm happy to hang out for another 10 minutes and, let's.
Great, thank you. And again, students, if you need to go, we certainly respect that. We will share the recording. In the meantime, if we can have 10 more minutes, this is fantastic. Thank you.
Let's see. So Camilla, could this be used with Bluetooth? Yes. So I'm gonna maybe hop back over. We didn't watch all of this one, but somewhere here, I think actually, maybe I'll go back. If we have a couple more minutes, I'll let this play.
What we're doing differently is using the blood vessels as the natural.
Using a stem drive device.
The promise and the hope of this technology is to regain independence for people.
So that was kind of a blown up view of what a stent, or they call it the stentrode, but it's basically a stent. And what they did was if you can see these little circles that are on it, they kind of made electrodes and put them on the stent, and then they have wires that kind of come back to a different place in the body.
Of this technology is to regain independence for people who have lost their physical independence. What we're doing differently is using the blood vessels as the natural highway into the brain and lacing the inside of the blood vessels with electrodes or activity from the brain. Those signals travel through a lead that exits out the body through telemetry unit that goes into a computer, and those signals can be.
Oops. So Camilla, to your question, today, this is kind of like what it looks like. So there's like this little, you almost think about it like a really small hockey puck, and it sits on the outside of the body, just over like a little receiver that's inside the body. And that's kind of how it's inductive communication. And that's how you get information into and out of the body. But that puck is connected to a wire, and the wire is connected to a computer. So that's like all the links there. What they're working on next is to take this and make it so that you put Bluetooth in it, and you can put like a little microprocessor in it, and then everything they need is right on the chest, and then it communicates wirelessly with the phone. So that's the next step of what they'll be working on, will be to make it Bluetooth enabled, just like you pointed out. So that's a great observation. Lauren, I see your hands raised. Do you have another comment or question?
Yeah, so with it going through the blood vessels and other things like that, do you think that people with blood clots, do you think it would affect them differently, or that it wouldn't be able to be used with them?
That's a really good observation. So I think like people with clotting issues, like that is kind of something you'd have to be aware of. But I think the advantage they have here is they're kind of standing on the shoulders of everything we've learned in the cardiac space with like kind of stents for cardiac purposes. So, if people have arteries that have enclosures, and so like we've actually learned, or that, for that disease and treating cardiac issues, we've learned a lot about the materials that you can make stents out of to avoid clotting issues. And I think, so they have the benefit of like having all that history in the cardiac space, and they can try to learn from that for their neurotechnology application. But you're absolutely right. Like clotting is something that they'll have to be kind of careful about.
Chris, I am seeing some very interesting slides there below. Blow our minds away with the future. Give us something that's really, this is future problem solving. What are our students here who are our future neurotechnologists, who are our future leaders? What are they going to see in the future?
So that's a great prompt, Cheryl. And I actually think that Vera, I hope I pronounced your name correctly. This is a really good discussion topic, and it's kind of safety and privacy concerns. So the comment or question was, are there any safety privacy concerns when it comes to using this technology and connecting it to the internet, for example, hacking and other malfunction? So I'll have a comment on that, and then we'll circle back to like the big picture future. And the short answer is like, absolutely yes. Like security and cybersecurity is becoming an ever important topic in the medical device industry. So we, here in the United States, for example, we're regulated by the Food and Drug Administration, or the FDA. And the FDA is like really, really interested in security and privacy right now. So there are actually groups where they kind of, their job, they try to hack devices, and it's not with malicious intent. It's really to identify what the vulnerabilities are and take that back to the manufacturers and say, hey, you guys have to fix this because, this patient is at risk. And there were a couple examples of that in the cardiac space with pacemakers. And I think in response to that, FDA is very much interested in security. new laws, Lauren? Yeah, so do you see any new laws coming into place when these become widespread? And I think, yes, there are already examples of, there's the privacy concern that Vera brought up. So like data, we talk a lot about data and AI and all these sorts of things right now. Like, who owns data? If you have all these things, like, do I own it if I'm a patient and I have one of these implants? Does the company that made the implant own the data? Like, the ownership of data is really important. And I think there are, I would say, emerging laws that are already starting to address that, and we'll see that continue in the future. Sam, I see your hand is raised. Do you want to ask a question or make a comment?
Yeah, I'm going backwards, but okay.
Oh.
So if you have like a cardiac stent, like what if it causes a kidney failure or like a stroke?
I don't know that space as well, to know kind of what some of the, I would say, like maybe adverse events that can happen with strokes. So I have to acknowledge it's not a space I know very well. It's kind of a little bit outside my area of expertise. So Camilla asked the question, can a brain implant be reversed or removed? That's one of the nice things, and I think Angela spoke to this a bit. Some of the historical approaches to treating some diseases like actually required like cutting out a section of the brain or ablating it with electricity or heat. So one of the things is to, once a lead is there, if it's not working as well as it should, you can at least turn it off and you haven't taken out or damaged brain tissue. So they consider it, I'll say it loosely in quotes, reversible. But reversible just means you're not permanently damaging any brain tissue. And you can have devices removed, actually. So there are examples where even patients that have deep brain stimulation implants, like something may happen and they decide to have the implant removed, and you can remove the leads. There's a little bit of risk there, so you kind of have to take that risk benefit trade-off, or patients have to decide what's best for them, but you can remove them. Michelle asked a question, in general, is the goal for treatments to be fully automatic after implanting? That is a great forward-looking statement. So I think a lot of these therapies, they're still very labor intensive. So you put the implant in, and then patients have to come back to the doctor a bunch of times to kind of get it just right. So that's actually one of the things we're working on at Medtronic, is how can we automate the therapy? How can we make it easier so patients don't have to come back to the doctor? If the therapy needs to be adjusted, let's make that happen automatically in the background. And, the patient, kind of just doesn't have to think about it. So I would say that, to your question, Cheryl, that's one of the big opportunities, is how do we make it automated? How do we make the devices smaller so they're easier to implant? And then how can we automate it so that it's doing the right thing at the right time? Those would be some of the other opportunities.
Lost in the bloodstream, is it possible? Lauren says.
That's a good question. So the way that stents are made, they're kind of mechanically made. I don't have a really good way of showing you, but they're mechanically made so that they kind of expand and they rest against the walls of the blood vessel. And then the blood vessel, there's actually a little bit of tissue that grows in, and they get anchored in pretty well. So it's not, I would say, probably not impossible, but pretty unlikely that, once a stent is placed, it would shift or move, because they kind of mechanically design them to expand. And you have to find the right size stent, right? Because you got to make sure that you're kind of, it's the right fit for the right blood vessel. So that's important, but as long as you get the fit, they stay in place pretty well. And Ava, I see your question or comment. Let's see. It mentioned in our research that because of how much neurotechnology has developed, people have been asking for new rules for what neurotechnology will be allowed to do. What are some rules you think we should have? That's an excellent kind of neuroethics question. I'll share an example. So actually I took an ethics class when I was in graduate school, and one of the scenarios we looked at, Angela talked a little bit about it, but you can actually use neuromodulation to alter people's mood or personality. So from an ethical perspective, what's an appropriate, like, why would we do that? When would we do that? You know, there are a lot of questions there. So like some of those ethical considerations, I think we'd have to think about and kind of maybe kind of put some rules in place for like, when do we deploy it? Another good one, and again, I don't have an answer here, but you can imagine, you know, it's plausible. We might find places of the brain to stimulate that might make us smarter, right? So now you've got a device that enhances some capability that we have. Well, who gets devices like that? When would we give a device like that? So there, again, there's a lot of like ethical questions that you have to answer. And I think some, you know, to your question about or comment on rules, I think kind of figuring out when we're talking about enhancing human capabilities versus healing, you know, at Medtronic, we're very much about like healing. So it's like restoring patients, but not necessarily augmenting patients. So I think we'd have to be really careful and intentional about how we would look at augmenting and kind of enhancing human capability. Camilla, but let's see, because many are used on Bluetooth, do people with brain implants always need the computer interface near them to have their implant function? That's another good one. And it's kind of a soft answer. It kind of depends. So they can be built so that they kind of, they may have some natural function. So a deep brain stimulation system, it's going to deliver the therapy to the brain no matter what it's connected to on the outside, because the patient with Parkinson's or dystonia needs that. And then there may be some other things that it does when it's connected, but it's always going to have that underlying function. This device, like this one here on the slide, this one probably doesn't do much if it's not connected to the outside world, because that's how it's designed, right? So it was designed, and the use that it's designed for is to interface with the outside world. So it's probably a combination of both. So I'm going to jump to Lauren's question on, in the future, will BCIs be able to help with conditions like ADD or OCD? I think yes. OCD is something that it's not a big treatment, but there's some researchers that are looking at the application of deep brain stimulation for treating OCD. So it's not as maybe common as Parkinson's and essential tremor, but that is something researchers are looking at. So kind of some of those disorders that have that kind of neuropsychiatric piece like that we're certainly looking at DBS, as well as depression and Alzheimer's. So those are other diseases that researchers are looking at using DBS for. Sam asked the question, how long do brain implants last? That's another, it depends. Sorry, I don't mean to be redundant, but so with deep brain stimulation electrodes to treat patients with Parkinson's disease, like Angela showed, those leads last for decades. What needs to be changed is the piece that she showed us in the diagram. There was like the little hockey puck looking thing that was, I think it was down in the torso in one of the diagrams. So that has a battery in it. So if it's a non-rechargeable battery, then those maybe get replaced every 5 years. You know, so you don't have to do the brain surgery again, but you do have to get that kind of the implant that's in the chest replaced. We also have rechargeable versions, and the rechargeable devices maybe last like 10, 15 years, maybe 20 years. So those get replaced less often. But the pieces that go in the brain, we hope that you build those and they kind of last the life of the patient, because you don't want to have brain surgery multiple times. Maybe there's one more question if there's one, and then Cheryl, I'll kind of hand it back to you to close.
Did you have anything else here in these slides that might blow us away?
Yeah, there was just a couple of videos. I think this has been good discussion.
And I don't want to steal too much of your evening, but I think we already have a lot of great ideas, because that you've given these young people to project into our future.
Exactly.
I have one more thing here that just,
Camilla, you may have raised your hands. I don't know if it was an accidental one, but feel free to ask a question if you'd like.
Well, I was just thinking, in the rechargeable, like how you said, like I know these days, like you can charge your phone by like just putting it on like a charging pad, but not actually connecting it.
Mm-hmm.
So is there something like that with the batteries?
Yeah, you're exactly right. So there's basically just like, I've actually had my phone here I had it on a charging stand sitting here on my desk. So there's like little coils that are in the back of our phones, and then there's another coil in the charger. So we built technology that's pretty much the same. So it's if you look at a physics textbook, there's kind of like induction, like the principle of induction is used to transfer power magnetically through coils. And it's the exact same technology in rechargeable implantable devices. So there's a little coil, it's attached to a battery, and then we build outside of the body a transmitter that transmits power, and then that's kind of inductively coupled with the implant. So you're exactly right. Awesome. So I have a lot of fun. You all are asking really great questions. It's obvious you're already well into a lot of your research. So just some encouragement to keep it up. And like Cheryl, you suggested it, if you're willing to send questions, and if you can kind of share questions with us, if there's advice we can give, Angela and I would be happy to help out.
Camilla says, thank you. I learned a lot today. This has been totally fantastic. So that, let's give them a round of applause. Okay. Thank you, thank you. Very exciting. So Chris, I know that you have little ones that you're going to be reading bedtime stories to. So we just want to really, really thank you, and thank you for opening the door for more questions. He might be able to send us a link or something to give us deeper, but keep those questions coming, kids.
Yes.
And I can hang around here a little bit longer in case there's just wants to be some general chatter. And Chris, we'll just let you get going. Thank you.
Okay, excellent. Thank you, Cheryl. This was a lot of fun. So good luck, students.
And we'll see what we can do about bringing future problem solving to your kids' school.
There we go. All right.
Okay. What can I say? Michelle laughs. I mean, it's my job. Okay. We know how important it is.
That's right.
And kids, anybody that needs to go ahead. Have a great evening. Stay in touch. Best wishes at internationals. I'm excited for you. I really hope that this has clarified some things of your research, added, and that you'll be sending more questions. You're inspired to research more. I see that TC has sent us a link about the implant to sense color. So if anybody wants to copy that or click on that, be sure to go ahead and do that. Let's see. Any other questions, thoughts? Go ahead, open up if you want to. Andrew, if you want to go ahead and stop recording now, some people might want to chatter a little bit and show